Welcome. This is the Department of Internal Medicine Grand Rounds. Today is a session sponsored by the Department of Internal Medicine Chiefs. So this is the Clinicopathological Conference Series, the CPC series, where we have invited attending physician to navigate a case as well as an expert. So look forward to that. 1 second, just a couple quick messages. We are remaining in a virtual environment for the rest of the spring for now due to multiple issues, but welcome everybody back virtual every Thursday, 12 to 1. A couple of things with the Q&As. As a reminder, you can chat in the chat box. You can also use the Q&A feature or ask to be unmuted, and we'll take some questions towards the end of the session. The CME and QR codes are posted in the beginning and at the end of the session, and will be in the chat box here in a minute. There it is. And lastly, it is a recorded session, and you can watch it afterwards and get CME credits through the website. So without further ado, I'm going to turn it over to Dr. Rasha Roslin, who is one of our internal medicine chiefs. Rasha?
Thank you, Dr. Bergman. And welcome everyone to the third CPC of the year. We're very excited for the case that we've prepared for you. I'm going to go ahead and share my screen. Let me know if you all can see it. Perfect. Okay. So the case that we have prepared for you is going to be Dr. Graham Gipson is going to go and navigate through the case. Dr. Gipson graduated with a bachelor's degree in biomedical engineering from Vanderbilt University. He then obtained his medical degree from the University of Tennessee before he came to VCU for his internal medicine residency. He stayed here for a fellowship in nephrology and is currently on faculty as an assistant professor in the Department of Nephrology. He also completed a master's degree in clinical and translational research during the last couple of years here. He also serves as one of the internal medicine residency program core educators. His research interests include clinical physiology of electrolytes, kidney function, and body fluid dynamics. So I'm going to go ahead and jump into the case. Okay, so this is just the format. We'll give 5 minutes for the case overview that I'll go over. Dr. Gipson will go over the case and discuss it and really analyze it and dissect it for the 35 minutes after that. And then we have a case expert who's going to be talking the last 15 minutes before we have a Q&A. The objectives of CPC, if you've been to one of these before, you might know what they are. It's really to identify key components in the patient's presentation, what is relevant in a history and physical exam and in the labs and imaging, and how to generate a differential diagnosis. And the way to do this is systems-based, starting very thoughtfully broad and then narrowing it down. And also to use evidence-based medicine to support diagnostic approach and use clinical thinking throughout the process. So we have a 50-year-old patient who presented to the emergency department with a 2-week history of new onset headache. The headache was initially intermittent, but then became more constant. The pain was not relieved by any Tylenol and got worse with activity. He also reported generalized malaise and fatigue. And 1 week prior to presentation, he had new onset hyperesthesias involving the left thenar eminence and right flank. He had no neck stiffness or visual changes and no diarrhea or rash. The patient is originally from India and recently traveled there in September, so 8 weeks prior to this presentation, to care for his father who had a stroke. On the way there, he flew through Dubai, then Kochi, and then spent most of his time in the Alaputta area. He then returned to the US 6 weeks later, so this is around 2 weeks prior to this current presentation. While he was in India, he denied eating any raw meats or fish, but he did eat raw vegetables. He frequently ate out in nearby restaurants as well. He drank mostly bottled water and no well water. He does report a remote exposure to freshwater lakes. He had not been caving and had no raccoon exposures that he knew of. He did report numerous mosquito bites during the trip, and he did not take any malaria prophylaxis. For the review of systems, mostly notable for chills but no fevers, myalgias, the headaches, which was his chief complaint, hyperalgesias of the left thenar, the right flank, and right temporal area, and the rest of the review of systems was negative. For his past medical history, he had a history of hyperlipidemia, hypertension, and osteoarthritis. He had no relevant surgical history. He had no significant family history. His father had a stroke, but he had no family history of autoimmune diseases. He was a previous smoker who quit around 15 years ago. He drinks socially 1 to 2 alcoholic drinks a week. He is in a monogamous relationship with his wife. He immigrated from India to the US in 2005 and had no other travel outside of traveling to India. He works in information technology in a business company. He had no allergies, and his medications were amlodipine and hydrochlorothiazide for his hypertension and rosuvastatin for his hyperlipidemia. For his vital signs, his blood pressure was 123/77, heart rate of 90, normal respiratory rate, normal temperature of 36.6, and he was sitting normal on room air. He had a normal BMI of 25. He was non-toxic appearing and was no distress. His HEENT exam was unremarkable. His fundoscopic exam was also normal. His neck was supple and had no stiffness. He had no JVD or carotid bruise or thyromegaly. His lymph exam was normal. His cardiac and pulmonary and abdominal exam was also unremarkable. His musculoskeletal system showed no effusions or crepitus or erythema. His muscles were non-tender. For his neurological exam, his cranial nerves 2 to 12 were intact. He was alert and oriented ×4. He had intact strength throughout. He had normal sensation except for hyperesthesias with very light touch to the left scalp, the left hand, and the right flank. His reflexes were intact. He had a negative Babinski sign. He had no tremor or clonus. He had a normal gait. He had no dysmetria or dysdiadochokinesia and no neck stiffness. As we said earlier, he had no rashes, and his psych exam was unremarkable. In terms of his lab and imaging, so his BMP was largely unremarkable. His creatinine was 1.08, which was his baseline. His CBC showed a hemoglobin of 16.6 with a hematocrit of 48.6, a normal white count of 7.1, and platelets of 229. The differential on that white count showed neutrophil count of 43%, lymphocytes of 24%, and eosinophils of 22%. His hepatic panel showed a total protein of 6.6, a normal albumin, normal bilirubin, and normal AST, ALT, and ALP. His ESR was 2, CRP was 1. His group A strep throat culture was negative. Influenza testing was negative. This was pre-COVID era. HIV negative, ANA was negative, and Lyme serologies were also negative. His urinalysis was yellow clear with negative proteins, trace leukocyte esterase, negative nitrites, small blood, negative glucose, 3 RBCs per high power field, 6 white blood cells, and no bacteria. His CSF analysis showed less than 1 RBC, 118 WBCs with 65% eosinophils and 26% lymphocytes. Protein was 46. There was a negative gram stain and no growth on the bacterial culture. He also had some imaging, including chest x-ray, PA and lateral, which was unremarkable. He also had a CT head without contrast and an MRI brain, which were also unremarkable. So now I'm going to hand the case over to Dr. Gipson, who's going to help us come up with a differential and a final diagnosis.
Hopefully. I'm told, though, that if you're in the know, you know what the answer is right away. So I don't know. We'll see how I do with this. You guys see my screen okay? Is my screen showing someone?
Yes.
Okay.
You can see
Thank you. Okay. Hi, everyone. A little nervous to be here doing this today, so bear with me. But I appreciate the invitation to give a shot at figuring this case out. As someone who likes to quantify things and do math and chemistry and stuff like that, this case was difficult. But I think I came up with sort of a quantitative way of figuring it out, which really I think is a technique that we do anyway with differential diagnosis, which is to do a cross tabulation of our objective findings and our history and possible things on the diagnosis or on the differential diagnosis, and then do little check marks and stuff, and wherever things line up the most is probably the answer. So I have a graphical version of that I'll show as far as what I mean about my approach. So get this going. Just as a recap of the case, I guess we need a summary statement. We seem to like to do that here. So I would say is middle to middle-aged gentleman who traveled to India by way of the Middle East and returned from there. And after about 2 weeks had onset of kind of disparate, multifocal, vague neurologic type findings. And so yeah, that would be my summary statement. And then the summary of the case in graphical form would be this. So I've highlighted that this man is primarily complaining of headache, hyperesthesia, which is an increased sensation of increased sensory function in certain areas in the left thumb and in the right flank, and of course on the head. As far as the travel goes, for those of you who don't know, I've shown a map here. So Dubai is in the Middle East. Let's see if I have, I don't have my little, had a little information card that would pop up, but it's one of the largest cities in the UAE, very popular tourist destination. I don't know anything about what this guy did there, whether he stayed in the airport and just changed planes or what, but he went through a large city in the Middle East. And then Kochi is a city in the Indian state of Kerala, I believe is how you say it. It's coastal, as I've shown in this circular inset. And the specific region where this gentleman went to care for his father, the Alappuzha region, is south of the city, still kind of coastal. And in fact, according to Wikipedia, in 2016, this area was voted the cleanest in India. So I don't know if that should change my differential or not, but anyway. And then the timeline is underneath. So 8 weeks prior to onset of his symptoms is when he traveled to India, and then he spent 6 weeks there. And then after 2 weeks back in the States is when the symptom onset came on. So what I wanted to, like the first thing that came to my mind with his travel history, his neurologic symptoms, and his pretty much benign exam, except for that tonsillar thing. I don't really know what that's about. And the laboratory and imaging studies, which were pretty unremarkable, except for CSF and peripheral blood eosinophilia. I came up with eosinophilic meningitis in a traveler as our as a starting point to figure out what's going on with him. And so that's what I'm going to focus on. Eosinophilic meningitis, by definition, is CSF eosinophil count of 10 per microliter or greater, or a CSF eosinophil percentage of greater than 10%. That's a pretty universally accepted definition. And the differential diagnosis for eosinophilic meningitis as a whole is huge, actually. I didn't appreciate the size of it at first because I actually started off this case by reading infectious disease materials. But besides infectious causes, you can have neoplastic causes, drug reactions within the brain that cause eosinophilia, something about ventriculoperitoneal shunts and other synthetic materials up there that elicit an eosinophilic reaction. So it is quite big, but most of the causes of eosinophilic meningitis do end up being the infectious variety. Chief among those would be parasites, since parasites are known to elicit more of an eosinophilic response than other infections do. Though you still have some fungus, bacteria, and viruses, and protozoans, I believe, that can cause eosinophilic meningitis too. So from going to the literature on this with my eosinophilic meningitis in a traveler as my starting point, I found a nice review article that gave a statistical breakdown of the most common causes of eosinophilic meningitis from parasites. And so I used this as a second starting point to try to figure out, just based on numerical data, what would be most likely. And so according to this, this table, cystic sarcosis would be the most, I guess we would say the most prevalent cause of eosinophilic meningitis, just based on the number they report, about 1 million total infected humans here for meningoencephalitis. Following that would be Angiostrongeliasis, followed by Schistosomiasis, and then Nathostomiasis. And then we have some other ones like Toxicoriasis, Balasascariasis, and Paragondomiasis. I know I'm butchering these names, but these are all parasites or protozoans, worms. And so what I did from this point was to take each of these and learn a little bit about the epidemiology and kind of the timeline that would be associated with the infection from each of these, what you would expect in terms of common manifestations of human infection, and then some laboratory and imaging findings with a focus on the neurologic investigations that you might see with each of these. And then I started filling out a table that would cross-tabulate the likelihood of infection for each organism based on the patient's pertinent historical laboratory and imaging findings. So the first one we've got here is Angiostrongeliasis. This is caused by the worm, Angiostrongylus cantonensis. Primarily, this organism is found in Southeast Asia, in the Pacific Basin, but thanks to shipborne rats moving around the world, we also see it now in Africa, South America, Australia, and over in the Caribbean and Puerto Rico and some of those, and Cuba. So human acquisition of this guy would come from eating the intermediate host, which is snail, slug, or mollusk, like freshwater shrimp, crab, or any raw vegetation that might have been slimed on by the mollusk intermediate. The average incubation period would be about 1 to 3 weeks, and so it's kind of our epidemiology and transmission. As far as clinical features, angiostrongeliasis primarily presents as neuroangiostrongeolysis, with headache being the most common symptom, followed by neck stiffness, vomiting, paresthesias, and all the literature is, they emphasize the hyperesthesia part of paresthesias. Fever being a variable thing, and sometimes motor neuron issues like facial nerve palsy or extraocular muscle paralysis. As far as pertinent findings for the lab and imaging for neuroangiostrongeolysis, CSF fluid would show high opening pressure. The fluid would be cloudy, not grossly turbid, not xanthochromic. It's been described as like coconut fluid appearance, which is gross. Protein can be slightly high. Glucose is typically normal, and you would have an eosinophilia within the CNS, so eosinophil percentage greater than 10. For neuroimaging, the CT findings are often normal. MR could be abnormal, show hyperintensity in various parts of the brain, but nothing that is really considered pathognomonic. And then peripheral blood eosinophilia is common too, but it doesn't correlate with CSF findings at all. So based on our patient's pertinent history and his whole picture, I filled in my little table like this. And so things that go in favor of angiostrongeliasis would be that he has a headache, he has multifocal hyperesthesia, he traveled to India, which is in the distribution of the organism. He ate raw vegetables, which who knows what was crawling all over those. I had to give a plus or minus, and you'll see I did this across the board, a plus or minus on 8 local cuisine, because I don't necessarily know what that means. Just because he says I didn't eat raw pork or fish doesn't mean that something didn't get undercooked. And so I will across the board give it a plus or minus. And then the normal brain imaging is kind of a plus or minus too, because you don't always see abnormalities with this organism. So that is that one. Nathostomiasis is the next possible suspect here. This guy is endemic to Southeast Asia, China and Japan, but also South America, Africa, Europe, gets all over the place too. Oh, in the Middle East. Humans would get this by eating undercooked meats, it's a 3rd stage larvae, or by drinking water that is contains the intermediate host, which is the small snail called Cyclops. Onset of the symptoms would typically be on the order of weeks, which would be kind of compatible with our guy. But the typical manifestation of nathostomiasis would be one of migratory cutaneous swellings that could be painful or pruritic, causing non-pitting edema wherever they are. Gastrointestinal disease would be another common initial manifestation, with fatigue, hyporexia, nausea, vomiting, abdominal pain, and variable fever. And then if you're dealing with neuronathostomiasis, which is less common than the first two, you typically have a really, really severe neurologic syndrome that's a lot more severe than neuroangiostrongeoliasis. So sudden onset headache, severe radicular pain, motor paresthesias or paralysis in the trunk and limbs. And if the tissue damage, like the parenchymal damage in the brain is extensive, then you can have signs of intracranial hemorrhage. So the laboratory and imaging findings, if you had really severe neurologic disease, your CSF could be grossly bloody or xanthochromic, which would have to do with the intracerebral hemorrhaging that could be present. High protein, normal glucose, kind of like the angiostrongeliasis, and then eosinophils, of course. For neuroimaging, if you have hemorrhagic complications, then CT or MR would disclose those things. But otherwise, there's not a terribly specific finding on neuroimaging for this. And again, peripheral blood eosinophilia is somewhat common. It's not the rule, but it's often more intense than for angiostrongeliasis. So going back to the diagnostic table, if I add in nathostomiasis, we get points for headache, malaise, fatigue, and chills. The multifocal hyperesthesia could sort of go along, perhaps not as strongly as angiostrongeliasis. A plus or minus travel to the Middle East, because again, I don't know whether he simply switched planes or if he had time to be exposed to the environment in Dubai. Get the point for travel to India, the plus or minus local cuisine again, and then drinking bottled water. The only reason I suspect this is because of a story my grandparents told me about traveling to Mexico, I believe, where they got bottled water too until they saw somebody filling it up from the spigot on the side of the building. And then they were like, oh, you get my point. We don't know if it's of good quality or if it really is just local water that's in a bottle. And since this organism can be transmitted through water infected with or that has the Cyclops mollusk in it, that could be a potential point there too. And then the normal brain imaging that this gentleman had is kind of a plus or minus. Cystic sarcosis is the next one. This is caused by the worm Teniasolium. This is endemic in regions Central and South America, Sub-Saharan Africa, India, and Asia. Higher prevalence is typically in rural or peri-urban areas, especially where pigs are raised. So I'm not quite sure how peri-urban, the Appaloosa region, is considered for this gentleman, but maybe it is. There are two different forms of disease. Teniasis is where the human gets infected and becomes a carrier. And then cystic sarcosis is the actual symptomatic disease where humans become infected by ingesting the eggs of the Teniasolium, which comes from fecal contamination of food or water. Whereas teniasis, the way we're classically taught, is you have to eat raw pork to get it. Cystic sarcosis does not necessarily come from eating raw pork, which is a common misconception. The onset of neurocystic sarcosis, so the neurologic disease from it, I found 3 to 5 years in a lot of things. So it kind of sounds like it takes a long time to develop. So that's kind of automatically a point against our traveler. As far as the clinical features, it's divided into parenchymal and extraparenchymal neurocystic sarcosis. Parenchymal being, of course, the brain tissue. Common things you find would be seizures, focal neurologic signs because of where these things insist in the brain, meningitis or encephalitis, so fever, altered consciousness, nausea, vomiting, those are more the encephalitis features. If it's extraparenchymal, then we're talking about cysts that are sort of free floating around in the CSF. And so you would expect to have findings that look more like increased intracranial pressure from hydrocephalus. So if you have intraventricular neurocystic sarcosis, you might have nausea, vomiting, and changes in vision because of papilledema that is coming from obstruction of CSF flow and intracranial pressure elevation, which I know we did not see on this gentleman's fundoscopic exam. If you get subarachnoid manifestation of this disease, you can look like meningitis, vasculitis, stroke, or hydrocephalus again. And then there's a spinal form of neurocystic sarcosis where you would have more radicular type symptoms, and if it gets low enough, even sphincter disturbances, like things involving the conus medullaris and cauda equina, that sort of area. As far as labs go, you would still have eosinophilic meningitis. That's common among all of these. That's where diagnosis, working diagnosis is. Typically have really high protein and normal glucose. So nothing really stands out about the CSF, unlike for Angiostrongeliasis and Nathostomiasis. For neuroimaging, though, you typically expect on CT or MR to see the little spherical cystic lesions in the brain or within the CSF, though MR actually is required to see them within the CSF. I don't think CT will catch it. And within those cysts, you see the little dot, which represents the scolex or protoscolex. And I did not deign to try to figure out all the different forms of the organism, but that is one of its stages of life. So you can actually see the guy inside his cyst. And then you have the edema and ring enhancement. So pretty characteristic looking neuroimaging. So for our patient, he gets points for headache, myalgias, since the cystic sarcosis can also manifest in other tissues besides the CNS, like the muscles. The multifocal hyperesthesia is kind of a plus or minus. I guess if he had this, it would depend on where the organism had encysted within the CNS. Travel to India is a plus, local cuisine still a plus or minus. And I gave him a negative for normal brain imaging, meaning a feature of his history that would count against the cysticercosis. Next up is schistosomiasis. So there are three major species that cause human disease: S. mansoni, which is primarily Africa and South America; Japonicum, which is in East Asia; and Hematobium, which is Africa and the Middle East. So the major exposure that you need to have with schistosoma with the organism is through contact in water, which is where the snail intermediate lives. So this guy had a remote history of freshwater lake exposure, if I'm remembering that right, but we don't know what his water exposures necessarily were when he was in India. So any kind of water activities will do. It could be bathing, swimming, scuba diving, water skiing, you name it. You just need water exposure. The typical first manifestation of disease would be the swimmer's itch, which is cutaneous schistosomiasis, localized pruritic papular urticarial rash, which is at the point of entry of the organism into the body. You can also get periportal fibrosis and eosinophilia. And then the Katayama syndrome is acute schistosomiasis, which has fever, malaise, nausea, vomiting, just a generalized illness along with the skin findings. If you're dealing in schistosomiasis, tongue ties me. This is often associated with people who have chronic exposure to the schistosoma organism, which would not necessarily be our guy. You would get myelopathy from this, usually manifests as a transverse myelitis and could involve the conus medullaris and cauda equina. And so it would mainly be lower body issues, leg paresthesias, lower motor neuron dysfunction, bladder paralysis, all those lower cord signs. And you could also get encephalitis, which would be manifest as altered sensorium, seizures, things like that. For labs and imaging, eosinophilia is really not the rule on CSF. It's present in only about 50% of cases, and the protein and glucose levels are not really that abnormal as a rule. Neuroimaging there's not really anything very specific as far as brain imaging, but if you're dealing with myelitis of any sort, you would see enhancement and thickening of spinal roots and just other MR findings of spinal involvement, which we don't have on this gentleman. We only have his brain. So schistosomiasis gets kind of not a lot of points. Gets a point for headache. Everyone's going to get a point for headache. Travel to the Middle East is plus or minus, and that would be the schistosoma hematobium that I'd be thinking about if he was exposed to that. And then the normal brain imaging is kind of a plus or minus too. I should have put a plus or minus on freshwater lake exposure because I'm not certain that he didn't make contact with freshwater in India. But if he for sure didn't, then this remote history of freshwater lake exposure isn't really that relevant because this is an acute onset of his disease. And so remote exposure, and it doesn't fit for me. Toxacara is next one. You can find Toxacara all over the place, worldwide distribution. This is the disease that's associated with dogs and cats, as they are carriers of the worm. Typically, exposure happens where there's contact with soil or sand. It doesn't necessarily have to be from petting the animal, but wild dogs and cats might use sandbox as a litter box, and then your kid goes there and plays around. So you commonly see toxicoriasis in kids playing in sandboxes, but I guess you could get it from anywhere where an animal has relieved itself or left droppings. So you have to ingest the eggs of this of the Toxacara. That comes from either soil, vegetables, or fruit. You can also get it from eating raw liver and other uncooked meats, which would contain the encapsulated larvae. So possible exposures for our guy. None of that's very specific to any exposure we know he had. The clinical features of toxicoriasis, though, are most commonly larva migrans syndromes, like visceral larva migrans. Visceral larva migrans. Commonly have liver affected in that case, but you can also have other viscera, intestines and things. You would have that manifest as abdominal pain, hepatomegaly, and then the general fever, anorexia, malaise, that sort of thing. You can also have cutaneous findings that go along where the organism entered the body if it came from soil or sand. And then there's ocular larva migrans where the organism gets into the eye and causes visual disturbances that way. So neurotoxicoriasis can have various presentations, and in the literature, there's not even really great, there's not a very good established causality between toxicoriasis and the neurologic syndrome. The evidence for it is just kind of weak, but it has presented, or is thought to have presented historically, as meningitis, myelitis, encephalomyelitis, all these things. As far as laboratory and imaging findings, CSF eosinophilia, again, is not the rule, but it can be really intense, having up to 70% eosinophils. It's pretty impressive. Protein and glucose, there's no whopping change in those. And on neuroimaging, you might have multiple subcortical, cortical, or white matter lesions, but not necessarily. Other findings you might have, if there's VLM present, you would have leukocytosis, eosinophilia, and hypergammaglobulinemia. And the peripheral eosinophils do not predict CSF eosinophils and vice versa. So for toxicoriasis, this guy gets a point for headache, the malaise, fatigue, chills. Doesn't get any points for, there's no evidence of visceral larva migrans syndrome because his liver function's okay. He's not complaining of abdominal pain. There's no skin issues going on. Middle East and India travel is kind of a plus or minus. Eating local cuisine, again, is a plus or minus, and so is the normal brain imaging. Baylisascariasis is our next one. This one, I could go through it, or I could just say right off the bat, it doesn't fit for this guy because he did not have the correct geographic exposure. This organism is found primarily in the United States, and it is carried by raccoons. And that was that was a historical point given in the case that he has not been playing with raccoons. And we also don't know where he lives in the U.S., but it just doesn't really fit with his story. Even still, the clinical features don't fit as well. No visceral larva migrans, ocular cutaneous larva migrans type syndromes, not there. If you have the neurologic form of the disease, it's often really, really severe, acute and progressive meningoencephalitis, lethargy, altered sensorium, ataxia, like really fulminant CNS disease, seizures, coma, things like that. The CSF has nothing special to differentiate it from other eosinophilic meningitis necessarily, nor does neuroimaging or peripheral blood eosinophilia. So this one I think is all based on where the patient has been and whether there were raccoons. So he gets a plus for headache and a bunch of minuses for lack of proper geographic exposure or exposure to the raccoon carrier. And okay, so Paragondomiasis. This one I have the most trouble with its name. Is our last one. This is an organism that's found primarily in the Far East, in Asia. China, Korea, Japan, Philippines, but also in India. Usually you have to ingest, this is crustaceans, so pickled crabs, crayfish, but you could get it from apparently eating wild boar as well, will give it to you. And the disease is primarily a pulmonary syndrome when it starts, and it takes about 8 weeks after infection for that to come on. If you have cerebral form of the disease, it's the most common form of extrapulmonary Paragondomiasis, but it's the most common of the uncommon manifestation, which is the extrapulmonary syndromes. You could have headache, fever, vomiting, stroke-like signs. You can also have a spinal form. Eosinophilia, not the rule in the CSF, and you would expect low glucose actually on this one. And then neuroimaging doesn't really, nothing terribly specific, unless you get the multiple conglomerated intensities with peripheral rim enhancement. That might be a clue. So for the last column, he gets a check for headache. The hyperesthesia is kind of plus or minus. I really gave anything that had potential for spinal involvement a plus or minus as far as the hyperesthesias go. Travel to India, he gets a plus. Eating the local cuisine is a plus or minus, and then the normal brain imaging is a plus or minus. So I didn't want to, I could keep going with all these different organisms, but I wanted to stick to those top ones. But other possible infections that he could have for which we have at least some information in the history is coccidioidomycosis can cause this. So he didn't have any caving and hasn't been to the Southwest as far as we know, and no pulmonary symptoms. The mosquito bites and no malaria prophylaxis. Malaria can cause eosinophilic meningitis, but it's exceptionally rare. And then for normal chest imaging, tuberculosis can cause eosinophilic meningitis as well, but is not as common as the ones I've laid out here. So my final diagnosis then would be I had to go with Angiostrongeliasis just by its the prevalence data, and it just felt that it fit right. So some explanations for why I didn't pick the other ones. Nathostomiasis doesn't really fit because he doesn't have cutaneous lesions. The CSF wasn't grossly bloody or xanthochromic, which is not always the case, but it's often how that would present as a more severe form of neurologic damage than angiostrongeliasis. The cystic sarcosis didn't fit. I think the onset was too soon. We're talking weeks rather than years. No seizures, no evidence of intracranial hypertension, and the CSF protein wasn't elevated enough. Schistosomiasis was not a good fit because no cutaneous lesions. The presentation is too acute, and the reason being that neuroschistosomiasis is more common after the chronic exposures. Toxicoriasis didn't fit because the larva migrans syndromes weren't there. Bayless ascariasis didn't fit because the geography was wrong, and lack of contact with the natural vector, being the raccoon, was not there. And then Paragondomiasis doesn't fit because there's no pulmonary syndrome to go along with it. So this is my best attempt to try to figure it out, and I think it's Angiostrongeliasis, which I've shown a picture of there. It's kind of a pretty worm, if you like worms. So, all right.
Thank you, Dr. Gipson. That was a very interesting case, and thank you for walking us through that. I'm now going to invite our expert to weigh in on the case and let us know whether we came up with the right answer, and to tell us a little more about the disease. Dr. Sangeeta Sastry completed her ID fellowship at the University of Pittsburgh Medical Center and came to VCU 7 years ago in 2015. Prior to her fellowship, she had experience in teaching learners at various stages of their medical education while on faculty at the University of North Carolina at Chapel Hill, Department of Internal Medicine. She's very involved with medical education here as a general ID physician, and she also maintains administrative positions in the Division of Infectious Diseases, as well as the Ryan White HIV program. So thank you for joining us, Dr. Sastry. We look forward to learning a bit more from you too.
Yeah, thank you, Rasha. I am going to share my screen here first before I... All right, are y'all able to see this okay? Yes, okay, good. All right, so first of all, congratulations to Dr. Gipson for doing a remarkable job. It sounds like you just had a mini ID fellowship right here, you know, especially with parasitology. That was really brilliant how you went through the presentation overall and how you came to your diagnosis. So I'm just going to talk about some of the key elements of the case and kind of work through some of the things that we were thinking of. You know, obviously this is an ID case. So some of the key elements of the case was that the fact that this person was a returning traveler from Southeast Asia. He had acute onset of headaches, chills, and paresthesia. Normal vitals and exam except for hyperesthesia to the scalp, hand, and flank. Peripheral eosinophilia, as Dr. Gipson mentioned, and of course the significant eosinophilia that was seen on his CSF. And of course, the normal brain imaging kind of also was an important aspect that we felt when we were seeing this case. So just going through some of the infectious causes of peripheral eosinophilia, I know Dr. Gipson did a really good job going through all of them, but I just want to touch upon some of the ones. You know, there's a reason why we ask for travel history in ID, because that really helps us determine, you know, diseases that are endemic in particular areas, and that would be of relevance to our case. So just looking at this particular article that kind of talked about some of the infectious causes of peripheral eosinophilia, for the most part, they are helminths that cause peripheral eosinophilia. Of course, there are some other non-parasitics like coccidiomycosis, fungal infections, cryptococcosis that can cause peripheral eosinophilia, but for the most part, you're looking at helminths. And specifically, given the degree of eosinophilia, it's more so of a tissue invasive helminthic infection. So some of the ones that I've highlighted over here, of course, I don't want to go through everything all over again, but there are several causes for peripheral eosinophilia. And the ones that we were kind of focusing a little bit more on, just as Dr. Gipson said, is more of the ones that were causing CNS manifestations, and specifically the ones that were more endemic in Southeast Asia, since the patient did report travel to India. Of course, he did stop in Dubai, but did not have much exposures there. And I think it was just an airport transit. So here, focusing on that, we are narrowing down the differential to a little bit lesser organisms than the prior list. And so we're coming up with Angiostrongeliasis, Cantonensis, Nathostoma, as well as Paragondomiasis. So coming to the other very important aspect of this case is the eosinophilia that was noted in the CSF. And that's pretty unusual to see that. And some of the infectious causes, again, as Dr. Gipson very nicely laid out, are here in this table over here. There are other non-infectious causes of eosinophilic meningitis, as you all probably know, like malignancy, sometimes even drugs such as ibuprofen, even ciprofloxacin can cause patients to have eosinophilic meningitis. But we're really talking about infectious causes of eosinophilic meningitis. And you know, top of the list again is Angiostrongylus, Cantonensis, Bailey ascaris, as Dr. Gipson mentioned, and then Nathostomia as well. We felt like the Bailey ascaris, again, with him not reporting any exposure to raccoons and it not being very endemic in India, so that's why we felt like that was a little bit less likely for him. And then Nathostoma as well. You know, just as Dr. Gipson mentioned, with the lack of cutaneous manifestations, the fact that, you know, he didn't have any xanthochromia on his CSF findings, that seemed a little bit less likely. So that brought us to Angiostrongylus infection. So Dr. Gipson did very well here in coming up with that diagnosis. So just to talk to you all a little bit more about it, I feel like he did a very good job in talking about some of the salient features, but just to go through it once more so you can hear it again. So some of the areas where we do see that it is pretty endemic in is mostly it's the southeast part of the world. So Southeast Asia, and then we're Pacific Islands, some parts of Africa. And interestingly, we do see some cases in the United States as well. And mostly the cases in the United States are from travelers. We have had, in fact, there was a case series that was published with around 12 United States students who had gone to Jamaica and eaten, I believe, Caesar salad, and they came back with Angiostrongeliasis. So, you know, it is possible that we do have that here. And of course, in Hawaii too, there have been some cases that have been reported. They've also isolated actually Angiostrongylus in armadillos in Texas. So there is some thought process that maybe those are the primary hosts, and then again the humans become the accidental hosts, and ends up that's how we get our cases in the United States. There are two key species to consider: Angiostrongylus cantonensis, which is the most predominant in the world, and then the other one is Angiostrongylus costaricensis, and so that's one that's more commonly seen in South America and the Caribbean. The types of or the clinical syndromes that come up with Angiostrongylus cantonensis are, there are three major ones. The most common being Eosinophilic Meningitis, very similar to the patient that was presented earlier. Eosinophilic encephalitis can occur, and if that occurs, it's very bad. It can be fatal. And so, really recognition of that earlier is important to be able to get the patient appropriate treatment. And then ocular strongyliasis is also another one where you actually see the worm in the person's eyes, and they can have vision disturbances, and sometimes it can be permanent vision disturbances. So very important to recognize early. But our ophthalmology colleagues are pretty good at recognizing it. It's, you see a worm in the eye, and then let us know about that. I'm sorry, I think I was on a prior slide before. And then looking at the life cycle of Angiostrongylus cantonensis. So this is a zoonotic helminthic infection with rats as the definitive host. And snails and slugs are the intermediate host, and humans are really the accidental host. First, the infected rat coughs up worms from the lungs into the throat, where they are then swallowed by the rat. Then the worm then goes to the rat's GI tract and is excreted via its feces. And then snails and slugs, who are the intermediate hosts, actually ingest these larvae. It goes through some developmental changes there, and then these get, the slugs and nails which could be contaminated are found on fruits and vegetables. If they're not washed or cooked properly, they can be ingested by humans. And sometimes humans can directly ingest some freshwater crabs, shrimps, prawns, etc. That can all frogs, and who have eaten some of these slugs before, and then therefore it can infect the human. Upon ingestion by humans, the infective larvae, they actually invade the intestinal wall, causing enteritis, and then enter the bloodstream and cause infection. The most common site of migration is the central nervous system, causing the main clinical manifestation, as we saw in our case, which was eosinophilic meningitis. And then the worms actually die in, they actually end up dying in human lungs or the CNS. So therefore, a human cannot transmit the infection, and that's why we call it an accidental host. This is actually a picture of a rat. Actually, they call it a rat lung worm, basically, and this is a picture of that emerging from one of the pulmonary arteries of a rat. And here are some of the clinical presentation or manifestations. As Dr. Gipson mentioned, the incubation period is around 1 to 3 weeks. Some of the common or the most common symptom that we see is a severe new onset headache with poor response to analgesics. And that's around 80 to 90% of cases actually do present this way. And the other big thing is the fact that, paresthesias and then, signs actually see hypersensitivity to touch is one of the most, is highly suggestive of this infection. And then, on exam, you could see some neck stiffness, related to meningitis, paresthesias, as I mentioned, or hyperesthesias. And then sometimes actually you can see no focal deficits. So that's around 30% of the cases can be that way. Then coming to the diagnosis, you could actually make a presumptive diagnosis just based on clinical grounds alone, with a triad of findings, and that's the characteristic symptoms and signs, someone who has eosinophilic meningitis on LP, and of course the right exposure history or traveling to the endemic area can help you make that diagnosis. And that's more of a presumptive diagnosis, but if you want to confirm, then you would do if you actually in the CSF, if you actually see the worm, then of course that makes your diagnosis. That's the gold standard, but it's a lot of times it's hard to do that in our CSF. And so actually these days what we do is a PCR testing of the CSF, where you detect basically the DNA of the Angiostrongylus Cantonensis. And actually for our patient, the CSF was actually sent to the CDC, who does this. And as you can see here, it was positive, so confirming our diagnosis of Angiostrongylus Cantonensis. And so how do we treat this? The treatment is case-by-case basis, but for the most part, make the diagnosis and you do it with LP, and the LP turns out to be mostly therapeutic, but as well as diagnostic. So we're doing both at the same time. And sometimes you require to do a follow-up LP to relieve headaches. The other thing to consider is giving high dose steroids, and it's found to actually improve outcomes in non-comatose patients in some studies. This study over here is a study that was done in Thailand, and it was around looking at a small group of patients. Obviously, this is pretty rare overall, but by giving high dose of steroids, it significantly reduced the days of headache and the number of repeat lumbar punctures required. And so there is some use of actually giving steroids for 14 days once you make the diagnosis. However, it's important to give this treatment early. Treatment overall, though, especially with antihelminthics, tends to be controversial, and it's controversial because of theoretical concerns that rapid worm death might exaggerate the inflammatory response in the brain and spinal cord. But we can use antihelminthic drugs, and that's albendazole is the one that's preferred over mebendazole, as it attains higher concentrations in the CNS. This particular study that I have quoted over here is also a Thai study. It was single-centered, randomized, double-blinded, placebo-controlled study, and really kind of told you the same thing as, by initiating treatment with this, you could really reduce the number of patients with headache, especially after giving treatment. So the headache definitely reduces, and having to do repeat lumbar punctures also gets reduced. It's recommended to start this treatment within 2 weeks of symptom onset, presumably because mature worms are less susceptible to the drug. The good thing is that albendazole is pretty well tolerated, and absorption is increased if you give it with a high fatty meal, etc. But really, if you give this treatment with steroids, it probably might be the most benefit for the patient. Next, coming back to the case. So by the time ID actually saw the patient, it was a couple of weeks. So when he came to see us, he wasn't in that 2-week window, and he was, some of his symptoms were actually kind of either stable or getting a little bit better. So when he was seen later on in follow-up, I mean, he did have some spinal headache overall just from the LP, but that actually improved. And then he did still have some paresthesias. We decided not to give him steroids or antihelminthics because he wasn't in that time frame. He was already clinically improving a little bit. And then overall, he had a spontaneous improvement a couple of weeks later on. So, we didn't have to do that or did have to do any specific treatment. And for the most part, it self-resolved. So that's basically the case, and I can take any questions.
Great work to both of you. We're Rasha, do you have any comments first?
No, thank you. Thank you both, Dr. Gipson, Dr. Sastry. That was great. Very educational.
Yeah, I feel like we can, print out some of your slides and make them one pagers. Very good overview of parasitology, and maybe we can even publish a little book there. But any comments, questions for the presenters? Looks like we have one question in the chat here. I'm wondering about the initial decision to do an LP. Obviously a good call, but not one everyone would have made. Any thoughts around that?
Yeah, I can take that. Again, our suspicion for infectious causes was pretty high. And with his CNS manifestations and headaches, again, having a little bit of experience in this, Angiostrongylus actually was pretty high on the differential, but really trying to figure out, what's going on just by the fact that he had this unrelenting headache. I think that was very important. So getting the CSF LP was what we decided to do.
Any other comments, thoughts? There's a follow-up question. Why was the ID consult delayed? We'll just consult you all on everyone in the emergency room. So,
yeah, actually, this patient didn't come to our ED. This patient actually was at an outside hospital. So it was initially managed over there, and they did not have ID at that particular place. So then they actually got connected with our travel clinic. And so that's why the consult was delayed. So they did not have immediate access at that point. Actually, at this point, you probably just called Dr. Gipson.
we have another question. If he is originally from that region, would that make the possibility of cysticercosis more plausible?
Yeah, that's a great question. He is originally from India. So yes, it is in the endemic areas. And so, yeah, he would have had years of exposure before. I completely agree with that, Dr. Meyer. But then I think the key point of all of this was that it seemed a little bit more closely related to his return from his travels. And so that's why that was felt to be a little bit more likely. But again, the characteristic findings, as Dr. Gipson mentioned, with neurocysticercosis is you're going to see some sort of lesion in the brain. So the fact that he had a completely normal MRI or a CT imaging, I mean, it just kind of went against it.
How likely would tuberculosis have been on the ID differential? Because it didn't make the final cut for me, even though I mentioned it. But that seems like a high prevalence area, perhaps, and it's on the textbook differential. So is it common?
Yeah, I know. Tuberculous meningitis is common in areas such as India, not common here in the United States. I think, again, with him being a little bit more of the acute presentation that he had, we did also have some initial studies like our TB IGRA that was negative, that kind of went against it. And then the CSF findings weren't very, again, when you see the eosinophil count in the CSF, that's the most striking out of them all. But yes, it definitely something to consider from travelers or someone who's lived in India or Southeast Asia.
Would you have thought that you would have abnormal chest imaging if that were the case? Like, can tuberculosis jump straight to the CNS without causing much pulmonary disease?
Typically, you are going to see at least some evidence of old, TB at least, and then probably even, something if he had latent TB before, if he had any sort of steroids, any other immunocompromising conditions or immunocompromising medications, that would kind of cause your latent TB to become an active TB process.
Okay. Thank you.
The final question here was just if I can paraphrase a little bit, if you were in the same boat and you were on the general medicine team, what was it specifically that triggered the idea to consult ID. Peripheral eosinophilia, recent travel, unexplained neurological findings, are those kind of the key things that should stick out?
Yes, I think so. I think we tend to get called a lot for travelers overall, but yes, these were the key findings that really prompted consult to us.
All right, well, thank you all so much, all three of you. Thank you so much for an excellent presentation. I'm going to ask Thomas to put the QR code back up, and we'll have the CME code in the chat. But thank you all so much for your time and preparation for this excellent job, Dr. Gipson, Dr. Sastry. Thank you so much. Appreciate it.
Thank you.